I'm a consultant physician working in the infectious diseases unit of Kenyatta National Hospital. And I'm here with Dr. Francis Ndiangui and Angela Sila, who will make their presentations on VCT as well as the lab aspects. So today we'll be covering the diagnosis of HIV. And the reason we are making this presentation is just to ensure healthcare workers are sensitized about the correct clinical algorithms for the diagnosis of HIV. Let me share my screen. Yeah. Yes. So I'll do the first part of the presentation. The presentation will be in 3 parts. So I'll cover a sort of introductory part. Then this will be followed by a presentation from the VCT team, and then a third presentation from the lab team. So we will take questions at the end of the presentations. So the reason for making our presentation today is to commemorate the World AIDS Day 2024, which was actually on the 1st of December yesterday. And the theme for the World AIDS Day is to take the rights path, my health, my right. So the World AIDS Day is recognized internationally, was commissioned by the World Health Organization. So yesterday was actually the 37th edition of the World AIDS Day. And the aim of this day is just to raise awareness of the AIDS pandemic. And with our theme this year, it's to ensure that everyone's rights are protected. So what rights are we talking about? The right to HIV testing, treatment, and care, the right to choose the HIV prevention methods that are correct for you, the rights to not be stigmatized, to face stigma, also the right to know your HIV status, that is to get tested and to get correct results. And if you have HIV and you're on treatment, undetectable viral load means there's zero risk of HIV transmission. And then lastly is also to speak out to ensure that HIV services are available to all people in the country. Sorry. So where are we in regards to the figures globally? So with regards to statistics, so there are 39.9 million people globally living with HIV in 2023. 1.3 million people became newly infected in the same year, and there were 630,000 deaths. 30.7 million of the 30.9 million were accessing antiretroviral therapy, and 88.4 million people have become infected with HIV when we look at it from the start of the epidemic. So 42.3 million people have died from AIDS-related illnesses since the start of the epidemic. So where are we globally with regards to the 90 targets? So 86% of people living with HIV worldwide know their status. But this means that 5.4 million people are not aware of their status. So 77% of those who know their status are accessing treatment, and of these, 72% are virally suppressed. So which are the groups that are most affected by HIV globally? And we'll see that these are the same groups that are most affected even locally here in Kenya. So the median prevalence of HIV globally is 0.8%. And the most affected groups, again, are women and young girls aged between 15 to 24 years, gay men and men who have sex with men, sex workers, people who inject drugs, transgenders, and people who reside in prisons. So in Kenya, where are we with regards to the figures? So we have 1.4 million people living with HIV, and our prevalence has really declined to 3.2%, which is the current figure, compared to what it was in the past. So in 1996, we were at 10.5%. In 2015, 5.9%. And you must admit we've really come down thanks to the good work done by the HIV programs. So, however, the prevalence higher in women than men. So women of reproductive age have a prevalence of 4.3%, while in men, the prevalence is 2.1%. In 2023, we had 21,000 HIV-related deaths. Now, when it comes to 1990, I think we can say we have achieved. 96% of people living with HIV in Kenya know their status, 94% are on ART, and 91% are virally suppressed. So currently we are working towards the elimination of mother-to-child transmission. So our focus for this presentation is on the diagnosis. So there are certain things that we'll go through just as a reminder, which you have to keep in mind as a clinician when you're choosing your test for your patient. So the first is the natural history of HIV. This is a slide that is, I'd say, common knowledge. So it's a plot of the immune system, the CD4 count versus time. And it also plots the changes in the HIV RNA levels with time. So more importantly, during the acute HIV syndrome, which is the first 3 months, you can see the changes here will affect the choice of tests at those particular points in time. So when a patient presents, you have to know where they are on this spectrum so that you know whether your choices are, your test is appropriate. So for the CD4 count at the start, the CD4 count is quite good, 1,000 when the patient gets infected. And then there's a sharp drop during the acute HIV, the first few weeks. And then when the immune system mounts a response and the patient becomes seropositive, the CD4 count will rise again, but will not reach where it was at the start. And then there'll be a steady decline as the virus continues to replicate. And eventually when it reaches very low levels and the immune system is depleted, then you start seeing the opportunistic infections. And this occurs over a period of years, about 9 to 10 years. Then with the HIV viral load, we see the sort of the reverse. So in the acute illness, there's an initial spike in the HIV RNA levels, and we see it can go really high to the level of millions of viruses. And then when the immune system is constituted, when the patient becomes seropositive, the viremia declines to a set point and is maintained over that level for years until the immunity is depleted. And then again, the viral load will rise. Oh, okay. Sorry, let me just turn up my volume. Just a minute. Just a minute. Yeah. I hope that is okay. Yeah, so how about, this is the progression of infection. So just putting it in another way, so from viral transmission, after about 2 to 3 weeks, you'll get the acute retroviral syndrome, which will last for a period of about 2 to 3 weeks. Then the patient will recover from those acute symptoms, and usually this coincides with seroconversion. So it takes about 2 to 4 weeks. Then now the patient will enter into this chronic HIV stage, which is what lasts for years, where they are asymptomatic until the immunity has declined sufficiently for them to present with opportunistic infections. So now they'll become symptomatic again. And at this stage, they'll present with the AIDS-defining illnesses. And if they are not treated within 1 to 3 years, then the patient may die. So this is important because there's a sequence in which these laboratory markers appear with regards to the progression of the disease. So from day 0, patient gets infected to about day 10, the first marker appears after 10 days, and this is the HIV RNA. So this period of 0 to 10 days where there is no marker detectable in the patient's blood is called the eclipse period. Then the RNA, HIV RNA is the first detectable marker. And then this is followed a few days later by the P24 antigen. And then much later, this is about 3 weeks after that infection, is when you now get to see the antibodies being produced. Yeah. So on the y-axis here, we've plotted the tests. So with time, the sensitivity of the tests have been developed, which are more and more sensitive, and they're able to detect infection earlier and earlier. And the first tests were known as the first generation assays, which were able to detect antibodies. Then we had the second generation tests, which were more sensitive than the first and could pick those antibodies a bit earlier, just slightly over a month after infection. Then we had this third generation tests, which included the P24 antigens, and they were able to make the diagnosis. They brought the window period even shorter, made it even shorter. And then now we have this fourth generation tests as well. Sorry, the third generation tests were also antibody tests, but employed IgM. And then we have the fourth generation tests, which are able to pick the P24 antigens in blood, and even able to cut down on that window period. So this is a table just summarizing the phases and the marker detection following HIV infection. So the phases of the illness include like the eclipse, during which there is no marker. We've already said that. Then you have the acute infection, which was the first 3 months. And you see the first marker to appear is RNA. And once you have RNA in blood, it remains positive. It's detectable throughout infection. So then there's the phase of acute infection and antigenemia. This is the phase now when the P24 antigen becomes detectable. For the P24 antigen, it's detectable for a shorter duration, like 2 to 4 weeks, because once the antibodies become positive, when the patient has seroconverted, then the antigen levels decline and they're not detectable until later in the disease, maybe when the immune system has declined so much that the antigen levels become high again. Then during the window period, this is from about 10 days, from that time of the eclipse till when you become seropositive, you're seronegative. Basically, you're seronegative because antibodies cannot be detected. And that's what we define as the window period. Then after the window period, when you become seropositive, then we say you have established infection. So now you have sufficient levels of antibodies, that's the IgG and the IgG antibodies, and they remain positive throughout the infection. So the whole point of this presentation was because of misdiagnosis, just trying to reduce the events of misdiagnosis. So there's a definition for what a misdiagnosis is. Any event where diagnosis is missed, inappropriately delayed, or incorrect. And it has a huge impact on patients because there's failure to link them to treatment in good time. You can cause social and emotional harm when you label a patient with a diagnosis and then later remove it. It also creates a mistrust of healthcare workers when there's a test, the test results are varying. Yeah. There's also a waste of resources where you have like false positives and the patient is put on ART, and ART maybe is a limited resource. So this is a case report of a patient who presented to care, which was published in a journal. So this patient had repeated false negative HIV rapid test results, and he had presented with advanced HIV disease. So he was a 45-year-old man from Tanzania, presented with characteristics of advanced HIV disease. So he had chronic diarrhea and dehydration. And on examination, he was wasted, had papillary pruritic eruptions, cervical lymphadenopathy, had features which were clear, suggestive that this patient could have HIV. So he had done a HIV test 3 times in the past year, and the testing had been done as per the government algorithm each time using the screening tests. So tested negative. His family, his wife and children were HIV negative. So when he presented to the facility, a repeat test was done and it was negative. But this time the clinician did something different. So he said this patient really looks like they have HIV. So he requested HIV DNA PCR instead of repeating the testing algorithm again. So this time the HIV viral load was 33,122 copies, and the patient actually had a CD4 count of 23. So he was immediately started on TLD and Septrin. However, due to the previous negative reports, the patient refused to accept his status and instead opted for traditional herbal medication, and he later died of an opportunistic infection. So there were gaps in the previous episode when the patient had presented and the results were conflicting. Maybe someone should have done something different earlier, which would have helped the patient. So what are the common causes of misdiagnosis? So one is if the patient presents too early during the window period. So when they have the acute retroviral syndrome, for example. So unfortunately, the signs and symptoms are non-specific. So it's just taking a good history that will help in picking the acute retroviral syndrome. So a history maybe of significant exposure and then put this together with the signs and symptoms. So in this table, we've just summarized some of the common signs and symptoms of acute retroviral syndrome. So this includes things like fever, fatigue, malaise, arthralgias, headaches, loss of appetite, myalgias. So really nothing specific, but more tying it in with the risky exposure, then we'll be able to guide you and make you suspect that this could be acute retroviral syndrome. Why is it important to detect this acute infection? Because the patients, may present with unusual symptoms, but starting that treatment early before the immune system has deteriorated will help to resolve symptoms and retard disease progression. And then these patients also tend to have high viremia. Remember from the diagram we presented on the progression of HIV disease, during the acute retroviral syndrome, the viremia can be as high as millions of copies. So these patients are really a high risk of transmission. So what are the other reasons for misdiagnosis? So there was this article, a systematic review, where they summarized the findings from several studies that were done on patients who had misdiagnosis and tried to see what are the commonest causes of misdiagnosis in HIV. So we can see the commonest cause was incorrect or suboptimal testing strategies or algorithms, i.e. where people do not follow the recommended testing algorithm. Or do things such as using breaker or using parallel testing strategies, or maybe they use a single test and they rely on that and label the patient as HIV positive. So other things include things like user error. For example, the person performing the test in the lab doesn't apply the buffer correctly, or maybe doesn't read the test correctly, or reads too early before the line has formed on the testing equipment. Then the other was the poor or inadequate management and supervision, maybe lack of training of staff. Again, the same thing comes, the poor adherence to testing strategies or algorithms, testing the patients too early in the window period. Then there were other factors, reactivity, clerical errors or clerical mistakes, maybe mislabeling of samples, and then using tests which are weak, which are not appropriate. So what are some of the causes of false positives? If the patient has autoantibodies, if the patient has infections that would cause a polyclonal B cell activation, then you could have false positives. If the patient has hypergammaglobulinemia, maybe if the patient participated in a HIV vaccine trial and was exposed to HIV antigens, so they'll remain positive. They could have a false positive test. So how about their test-related issues? So certain tests have been known to give sporadic false positives, such as the OraQuick. And this is the reason in the algorithms, any positive test has to be confirmed by a second test. Then there's also cross-reactivity with nonspecific antibodies. For example, in patients with collagen vascular disease, autoimmune diseases, lymphoma, liver disease, multiple sclerosis, and even pregnancy. How about false negatives? If you test the patient during the window period, they will not have formed antibodies, and our screening tests are for detecting antibodies. So of course, they'll test negative. So testing late can also be a problem. So like for the patient we presented, when the immune system is already depleted, so patients who have advanced HIV, their CD4 count is low, the immune system is so depleted, they're not producing sufficient levels of antibody. So in that case, you could also have a false negative. And for these patients, then it becomes important to keep that in mind and be able to order a PCR. So there's also from literature, people infected with certain clades, but I think they've tried to make the tests able to detect as many of the HIV-1 clades as possible. Then if the patient has HIV-2 infection, because our tests are just mainly for testing HIV-1, geographical area is mainly in West Africa, so history will be good in picking up whether the patient was exposed. Then if you use less sensitive tests, and from literature, they are saying the automated tests tend to be more sensitive than the rapid tests. So the quality of the tests that you're using is also important. Then the sample taken. So for example, a test on saliva that uses saliva would be less sensitive than one that uses blood or serum. Then patients who have immunodeficiency, for example, not producing antibodies, agammaglobulinemia, And then there are also maybe technical errors in running the tests can also lead to false negatives. So in conclusion, it's important to adhere to the appropriate testing strategies to reduce the rates of HIV misdiagnosis. Then also just to keep in mind that false negatives and false positives do occur, but you have to follow the algorithms so that you're able to make a diagnosis in time for the patient. Thank you. So now I'll hand over to Angela. Just a minute.
So good afternoon, everyone. Thank you, Dr. Juma, for that good presentation. I'd like to continue and pick up from there, just like you have said. My name is Angela Silla. I'm a medical laboratory officer and a counseling psychologist. Currently working at the VZT and HIV prevention unit. And my mother department is the laboratory medicine. So I'll be taking us through rapid HIV testing. Just for us to appreciate what is the role of testing. And of course, after testing, there are other services from the HIV program that we provide. That clearly the HTS refers to the full range of services that our client is offered together with HIV testing. Testing is the gateway to HIV and care, plus any other services that a client that has come for testing would require. Early and sustained HIV diagnosis and treatment can help people live long and also live healthy lives. So we're saying that, again, HTS makes the first steps in the clinical cascade to ensure that HIV diagnosis, linkage to care, and subsequent viral suppression. As we all know about the UNS cascade of the 95, 95, 95. So we have the core principles that guide the services that we provide, and these are the 6 C's. These 6 C's are again based on how they are consistent with the international policy and the technical standards. So the services that we provide are purely based on these 6 C's. We call them a cornerstone, and that is, we're talking of the consent, where a client to be given an HIV test, or before a client is tested for HIV in rapid testing, we require them to give a consent. This consent can be written, can also be verbal. Then again, confidentiality is very key. Indeed, every information about that client that you're handling is very, very, very important, should be held confidentially. But again, we also appreciate the aspect of shared confidentiality for purpose of referral and other services that that client may require. Then we have counseling. We consider counseling before the test very important so that this client can be prepared or given adequate information so that they can be able to make informed decision about the test. And it is out of that they can be able then to say that they consent for the test or they do not consent for the test. Then we talk about correct results. Essentially, everybody who goes for a test, HIV or any other, would be most satisfied if they get the correct results, and equally the same in HIV. And so we ensure that the results that are given to clients are correct and they are reliable. After doing the testing, or rather looking at the aspect of correct results, then we have the connection to care and also to prevention and other appropriate post-test services. That would be treatment, that would be psychological support, and any other support that this client would require. Then we also talk about creating an enabling environment for HIV testing services. And this is where we would want to ensure that we respect and the rights of the client, talking about discrimination and stigma, to ensure that such as that does not arise, and various other things that would prevent a client from accessing the services. We also look at intimate partner violence, or generally both also for the client and also for the service provider. And that is what we are referring to as the enabling environment. So those 6 C's are a real cornerstone for our services as we provide. Again, the HIV testing services, they are provided as a package. So this is the basic package that a client would receive. And like I've just mentioned earlier, we've seen that counseling is very important. So we have the aspect of pre-test counseling, whereby the client is now taken through, prepared for the test, given information, told the benefits, that they can be able now to make a choice whether to take up the test or not to take up. Of importance to mention is that in HIV testing services, there is no coercion for the test. One is expected to opt in or opt out or give consent for it. Then after the pre-test, then there is now the testing. After the testing, depending on the results that come out, then we have the post-test session, whereby it will be guided by the test results that you have. Then we have assessment of other health-related conditions, such as TB, and then other opportunistic infections, and there may be other services that the client may require. So as they interact with the counselor, then the counselor is able to tell what other services can they refer this client to. Then again, the final one is about the referral and linkage to other appropriate aid services. And here we are talking of when we have done a test, you can have negative results. And for any negative results, we shall refer that client to preventive services. And in case it is a positive result, the client then is also referred for treatment and care services. Then we have guidelines or guidance on how HIV diagnosis is done, and that is, of course, by WHO. And the recommendation by WHO is that there should be multiple and pre-qualified serology assays as part of a testing strategy. And this is in the event where one is using the rapid diagnostic test and also the enzyme immunoassays. And so to obtain the World Health Organization pre-qualification, each assay as it is should be able to demonstrate these two aspects which are very key, and that is the sensitivity and specificity, where we are saying that the sensitivity should be above 99% or equal to 99%, equal to or above 99%, so that we can be able to have very few, if at all, false positive results. Then we have the same assays being able to have a sensitivity or specificity of either equal or above 98%. With that then in place, it also recommends that we ensure that the positive predictive value is increased to as high as above or equal to or above 99%. And this is also in all settings whereby testing is taking place for HIV. So again, the same guidelines indicate that the algorithm-based testing is important instead of singular test, and is preferred to enhance test results so that we have the PPV enhanced, increased to as high as possible. Again, the guidelines also recommend that the testing algorithm be used to influence the accuracy of the HIV status that are going to be reported for any client. So verification of the testing algorithm has been conducted or is always conducted. And now, as we shall be seeing in a short while, we are at a point of transiting to a 3-test algorithm. And this is what we are saying, that has been recommended and the verification has been done. So accurate HIV results are essential since they are the entry point to treatment and also to prevention strategies. So in an ideal algorithm, the test should not share the same false reactivity. So these are the tests. I have just mentioned that we are at a point where currently we are using 2-test testing algorithm, but we are in a transition period where in the next, probably next 1 month or so, we will have transitioned to a 3-test algorithm. Maybe this is happening from facility to facility or county to county, I should say. However, the transition is well coordinated by the National AIDS Control Program, NASCOP. And so they are overseeing that transition. But I will be talking of the current the current 2-test algorithm, and these are the tests that we are using. The first test being determine, the second, which is used in general population. The second test being the duo. Rather, in PMCT, we also have another screening test, which is the duo HIV syphilis. So let me just make it clear that we have the screening test for general population determine, for PMCT, the duo HIV syphilis. Then we have the confirmatory test, which is the test 2, and this is first response. And in this current algorithm, PCR is recommended for inconclusive results. In the event where test 1 and test 2 do not give the same results, currently we recommend PCR to be contacted for that patient or client. Then we also now have the 3-test algorithm, which is in transition, or the country is transitioning to. So we have test 1, and they are 2, because again of the different populations. We have TrinScreen as test 1 for general population, and we have, which is for PMCT. So those 2 are screening tests. Then we have now test 2, which is 1 step. It's a confirmatory test. After you have done test 1, it is positive. You do test 2 is positive. Then you go to test 3, which is also a confirmatory test. I'd like to emphasize and say that it is not a tiebreaker, but it is used to minimize the chances of false positive, so that we ensure that any positive result that we shall be giving to our client, or a positive HIV diagnosis, is then actually the actual status of that client or that patient. So both the current 2-test algorithm and the 3-test algorithm is for diagnosis for all persons above 18 months of age in the HIV program. For children or for population under 18 months, then the nucleic acid tests are conducted. I just mentioned that we are transitioning from 2-test to 3-test, and probably one would be asking why the change. And I'd like to say that for accurate results, WHO recommends the use of HIV testing strategy that achieves at least a 99% positive predictive value. So that, of course, we have less than 1 false positive for every 100 people that are diagnosed with HIV. So the PVV is the probability that an HIV positive diagnosis is correct at a population level. So WHO encourages the use of 3 consecutive reactive tests for an HIV positive diagnosis. This is actually very important, as a treatment is adjusted. As treatment has been adjusted, where we are talking of test and treat. And again, the national HIV prevalence has continued to decrease, like we've just heard from Dr. Juma. So it is declining over time. And so the more reason why we should be having a raised or enhanced positive predictive value in the test methodologies that we are using. So I'll be taking us through the algorithm very briefly, just my mention. So this is the current 2-test algorithm. And we have a test 1, which is the screening test. And in the event where we carry out a test and the result is none, where the results are positive or reactive, we don't stop there. You go to a second test, which is the confirmatory test. And we, again, test, and with that confirmatory test, if the results are reactive, we consider that as a positive result. However, in the program, we do not stop at that. We will now have that client referred for retesting to a second person, another HIV testing provider, to test that client or that patient again and see whether they will still get the same results. That is, if the test turn like the way it was for the first tester, then that is the only time that there is the patient will be referred or initiated to care. I just want to go back to, I think I'm using the cursor, I guess everyone can see that. So we are at the confirmatory test. We have done a test with the confirmatory test, test 2, and it is reactive. So we report positive and we refer to a second tester. This second tester can be at the comprehensive care center, and they can also be in another facility, depending on the setup of testing in that facility. However, we can also carry out a test with the second test and it turns non-reactive. So in such an event, we consider that result inconclusive for reason the first test was positive, and now the second test has given us, rather the first test was reactive, and now the second test has given us non-reactive. So we consider that inconclusive, and we refer this patient or this client to a second tester so that they can also carry out the same test. And if the results turn the same, then a PCR will be taken, and a sample for PCR will be taken, and the patient will be subjected to PCR testing. So I want to go to the second tester. I guess we can see the cursor where we are. So the second tester, what they will do after the second, after the patient has been referred to them. So they will start just like the first tester did with a screening test, test 1, and they will do a test. If the results are reactive, if the results turn reactive, as it was for the first tester, then a confirmatory test will be done a second time. If the results turn reactive, then that is considered a positive result, and the patient will be enrolled to care. Essentially, this second testing person is expected to be either placed at the CCC or in another facility, depending on the setup in the county of origin of that patient. But again, the same screening, the second tester can also do the test and get at the point of test 1, the result turns non-reactive. Non-reactive. Remember, the first tester got the report, the result as reactive, and so was considered a positive test result. But now the second tester has done the test and the results have turned with the screening test non-reactive. So at that point, the second tester considers that result as inconclusive. And what they will do is to take a sample for, they will request again for a retest. They will request for a retest. And if the retest is done and the samples, the results are still inconclusive, then a sample will be taken for DNA or PCR, and that shall be considered the final result of that patient. And this is, the sample is taken as a dry blood spot and sent to the laboratory for that DNA PCR. I do not want to lose you because there's another test result here that can also be can come out. It's another outcome that can be when we are using, when we are at the second tester. The second tester can do the first test, and with the test 1, the results are reactive. But when we go to test 2, this one, the confirmatory test, the result turns non-reactive. At that point, then that result is considered inconclusive, and a DBS will be collected and the sample will sent to the National Reference Laboratory for a DNA PCR. So you will see that we have different scenarios where we can have inconclusive results when the first test and the second test do not agree. And for all those, we always call a second tester, and if the result still turns inconclusive, then a PCR test is done, and a DBS is collected, and the sample is sent for PCR test. So there are this possible inconclusive result scenario. We have another possibility of an inconclusive result, and we have another possibility of an inconclusive result. But all that is taken care of by the fact that in the event where you get an inconclusive result, the same shall be repeated by another tester. And if they come up with the same result of being inconclusive, then dry blood spot will be collected and sent for DNA PCR. So that is what is currently happening. That is the current two-test algorithm. I'd like to go to the three-test algorithm, but before that, I just want to say, just like we had said earlier, that test 1 has a sensitivity of equal to and above 99%. And so it has an ability to correctly detect the presence of HIV antibodies. And test 2 has a specificity value of equal or above 98%, and it has the ability to correctly identify the absence of HIV antibodies. Test 3 has a specificity value of equal to or above 98%. So this test, which is a second confirmatory test, it provides definitive HIV positive status by increasing the PPV of the algorithm to 99% or above. So I'd like for us to see how this comes about, and probably we may want to go one by one so that we go faster. This is test 1. So in test 1, like we had said earlier, is a twin screen. And when you have done the test and the result is non-reactive, you just report as negative and you link to prevention services. But if the test is reactive, then you go to the second test, which is one step. And if it is reactive, you go to the third test, which is first response. And if it is reactive, then you report as positive and refer for second HTS provider, who is, like we have said, will be stationed at the CCC or in another facility, depending on the county of origin. And this second tester will equally do what the first tester has done, so that before the client is initiated to care. I'd like to say that you can have a test, and with the first response can also give you a non-reactive. That is a scenario where the first response can give you a non-reactive result. So in such a case, what happens? That is considered inconclusive, and a retest is done after 14 days. But again, also with the second test, which is one step. You can also get a non-reactive. It is also possible. It's another scenario. Remember, the first test was with TrinScreen was reactive. Then the second test with one step is now turning non-reactive. What do you do? So what we say that you repeat the test with TrinScreen, and the result at the repeating can be non-reactive. And if it is non-reactive, you report that result as negative, and you link to prevention services. However, the result can also be reactive at the point of repeating. If it is reactive at the point of repeating, then you consider that inconclusive and you retest after 14 days. There are various scenarios. We are going to see another scenario now, whereby we are saying after 14 days, and it still continues to be inconclusive, you report negative and you advise to test after 3 months. That is in the current algorithm, rather in the algorithm which we are transitioning to, the 3-test algorithm which we are transitioning to. So like I have said, in the 3-test algorithm, just like it was with the current algorithm, we have a first tester and a second tester. And I'd like for us just to quickly check at how the second tester scenario is. The second tester, in essence, does exactly what the first tester has done. But the second tester is carrying out the test to ensure that the results are actually reliable. It is more so for quality aspects, so that before any client is initiated to care, the results then are known to be true positive or true negatives. So I'd like for us to look at the second tester, and we see now we are using test 1, which is TrinScreen. And there is no much difference. The testing, the lineup is the same. And so here you will see TrinScreen is used, it is reactive. Then one step is used, it is reactive. Fast response is used, it is reactive. Those are the 3 tests. Then in that event, you report as positive by the second tester. And this second tester is the one who will then refer for initiation to care. The first tester, I'd like for us to note, will get a positive result, but will consider as positive and refer to a second tester. Then the second tester now will report as positive and initiate to care. So again, with TrinScreen, you can also have an unreactive result. And what we say is, and that is the second tester. If the second tester tests with TrinScreen and the result turn non-reactive, and from the first tester, the 3 tests were all positive, then that is an inconclusive, and this client should be tested after 14 days. The same with fast response. You can also have an unreactive, and this, in such an event, you report inconclusive and retest after 14 days. Again, with fast response, you can also have a non-reactive result. In such a case, we say, if the first result was reactive and the second result is non-reactive, you actually repeat the test with TrinScreen, just in case there were some errors that were there. Then if it is non-reactive, you report that as negative and you link to prevention. But if it is positive, then what will happen? You will consider that, rather if it is reactive, you consider that as inconclusive and retest after 14 days. And like we had said also for the first tester, if after 14 days, this client or patient is back and they still report, or rather the result is negative, yeah? the result is inconclusive, sorry, then you will report as inconclusive and repeat after 3 months. Yeah. I'd like to say that again, in the lineup of testing, we have a scenario for PMCT. Testing in PMCT actually is not different, but it is just the type of test that is used, which is the HIV syphilis duo, whereby we want to be able to detect whether the client or the mother who has come for PMCT could be also having syphilis. So that is why we are using that. The scenario is not different. The only difference between this and the other one is just that we are using the HIV syphilis duo, which is the standard Q. That is the only difference. So the rest remain the same as we have seen for the first tester. Something I'd like for us just to see, I know when we do this, look so how the algorithm will look like in PMCT for the first tester. And I would just like to mention that the second tester, we equally go through the same scenario, but the difference is that at the second tester, they will not test with standard Q, but they will test with trin screen in this algorithm. Of importance to mention is that when we test and the syphilis is positive, when we test and this result for syphilis is reactive, if to say, then we report positive and we consider treatment for syphilis right away. For syphilis, we do not do a retest. We just straight away go for treatment for syphilis, right? So that's how the algorithm is. And now, like we have seen, once all that testing is done, we refer that client to a second tester. And the second tester, like I've mentioned, the only difference in PMCT is that the second tester will use trin screen instead of HIV syphilis duo. That is the difference, or the standard Q. That is the difference. Okay. So I'd like to see how it looks like finally. And that's how it will be looking like for the second tester. I'd like to say that it could be a little bit such a mix-up when you have to check out how this testing is being done, but it's not very complex. It just comes depending on which test you have done first, the second test, and the third test. But I'd like to emphasize here that we do not interchange the tests. We do not say, now that you have the 3 tests, you can start with first response and go to 1 step and go to trin screen. In the algorithm, we follow the lineup because of the aspect of the sensitivity and specificity. So it's a plea so that we also don't interchange the tests. As we go to wind up on my part, I'd like to say that you have seen that there will be reasons for retesting with the presentation by Dr. Juma. We had scenarios where a client is testing negative, and it's not that they are actually negative. Probably it's for reasons of seroconversions. And so different populations are given recommendations to test at different points in time. And so these are recommendations for retesting according to NASCOP, whereby we have a general population, where we are expecting that the retesting should be done 2 years down the line, unless there is a risk. Then they should be tested on quarterly basis. Then we have the vulnerable population, where they retest biannually. Then we have negative partners in discordant relationship, whereby we are saying that they should be able to retest at the initiation of ART for the positive partner, then retest every 3 months until viral suppression is achieved. Then report at 6 months, or rather retest at 6 months and 12 months, then annually if the positive partner remains virally suppressed. Then again for pregnant women in first trimester and third trimester, and during labor or in delivery. Then breastfeeding mothers, we expect that we retest them at 6 months, or rather 6 weeks after delivery, or at 6 months, then every 6 months until completion of breastfeeding. Then we have a client with recent HIV exposure and initiated on PEP. We expect they'll be reinitiated for retest at 4 weeks. For negative clans, test at 3 months, after which usual guidelines should apply, whereby the guidelines we follow appropriately as expected. Then we have individuals on pre-exposure. We test initially and then pre-exposure. Then we test initially, and then depending on the exposure, then testing shall be done. And I think that brings me to the end of the retesting guidelines. Let me just say that for diagnosis of HIV, there are key aspects where we need to ensure that we have continuous quality improvement so that we ensure that we get the correct results. So that is as far as strengthening QA measures and mechanisms in the area of testing, applying interdisciplinary approach for all stakeholders, then improved communication between all stakeholders, as it were, and proper documentation that we can be able to prevent any adverse events. And I think I want to stop there, and probably you'd want to pick up. Dr. Juma will be invited.
Yeah, thank you very much, Angela. That was an excellent presentation. It was very detailed. You took us through step by step, and I hope we've learned a lot. So I'd like now to invite Dr. Francis Ndiangui, who will now present on the lab aspect. Thank you. Dr. Ndiangui, welcome.
Thanks. Okay. Just a minute. I'm trying to share. Good evening. I hope my presentation is on.
Yes, I can see your slides, but you're not in presentation mode.
Okay. That's there?
Yeah, now it's okay.
Okay. So thanks, Angela. I think you have really outlined the diagnosis in terms of the algorithm. And just to highlight, or just to repeat, the purpose of testing is to provide accurate HIV diagnosis as per the approved testing algorithm. The purpose being, the issue being, you want to bring in the back of the mind that laboratory testing, there's no test that is 100% accurate. There is always an aspect of trading between the sensitivity and specificity. So you want to improve on both. So I just want to do few highlights on the definitions. I know it has mentioned about test strategy, and testing strategy just means it's a sequence of tests conducted on assays to achieve a specific objective, such as are you aiming at screening for infection? Are you winning as diagnosis, or are you or it's just a diagnosis? So that will it will define on the will define on what the strategy or what you want to achieve. Then the testing algorithm is those specific products, in this case, assays that are populated into a testing strategy so that it forms the algorithm. Remember, these are usually validated and they can change over time. As Angela has indicated now, we are going back, we are the country will go or is starting adopting the three test algorithm from the two that has been there. Then you have talked of the discrepant results. These are when two or more assays do not agree. For example, if you do an assay one, assay or test one is reactive and the other one is non-reactive, then that's, you say there's discrepant. Then you can do a repeat test, like when the same, where you can do repeat on the same specimen on the same, at the same sitting of that assay when you have those discordant results. Then retesting is when you have take a second specimen from the same individual and is tested again following the same testing algorithm. That's retesting. So it doesn't have, it is a different sample, not probably in the same sitting. Then you have confirmatory tests, which is an assay which definitely confirms this in the initial reactive test and provide a HIV positive or negative results. Then you come about, I know Dr. Juma had mentioned about the generation of tests and in ELISA testing. And this is all about testing and closing the gap of how early you can diagnose or you can pick the infection, HIV infection. And it was really extrapolated on what is the duration. And the first generation assays when HIV started in 1985 was, I think as early as 1985, it only detected IgG, the antibody to anti-HIV, to HIV-1. And this infection could only be caught up at around 6 to 12 weeks post-infection. Then there was the second generation, which was added IgG to HIV, and this reduced the period to 4 to 6 weeks. Then came that generation, which is just, it included also IgM detection, antibody IgG, and also IgG to blood, to group virus group O. And this reduced the window period to approximately 3 weeks post-infection. Most of the tests now currently, or where we are, is fourth generation, which now added to the tests of test to PV24 antigen. It can included in the assay, hence now reducing the window period, or rather the time taken since infection to 14 days, at least 2 weeks. So that's the as far as now ELISA is concerned. Then the issue of that now fourth generation, it makes the test more sensitive and achieves a sensitivity of 100 up close to 100% and a specificity of 99.5%. I'm just taking a case of what we use in the lab, and for now in KNH, that the kit we use, it is on antigen antibody platforms, and it estimates the manufacturer's information is that is 100% sensitive at a 95% confidence interval, while the specificity is up to 99.92%. According to published data, also sensitivity for determine is a determine kit, just as a reference, is also 100%, which is a rapid test kit. Is highly sensitive. While all these methods meet the WHO minimum requirement that HIV assay test should have a very high sensitivity, at least 99%, and specificity of 98%. Their performance will just that there's a fact of possibility that you may have a false positive and a false negative results, which is an inherent limitation in any assay in the laboratory. So that's what in the back of our mind that we should be aware that that's possible, that you may have that aspect, that you may have a false positive or false negative is a trade-in of a test require, or when you are making a test assay. So then you have the laboratory tests used in HIV. Just to highlight, I think we have talked of rapid tests, but they all utilize the antibody and antigen tests. You are either detecting the antigen in the for the specific virus or any organism, or you are testing the antigen or antibody, which are either rapid diagnostic tests. That's what Angela has presented in terms of what are used in the testing or the testing algorithm. Then you have long ELISA methods. These are the one that we use in the laboratory or in the main equipment, laboratory equipment. Then, of course, he also mentioned about nucleic acid testing, or PCR, which is now is able to identify, to amplify the virus, and you're able to detect even at a very low level. Then you have viral loads. This is not really for diagnosis. I think it's just it's not used for diagnosis. The WHO guidelines of 2019 recommends that to use the 3 different consecutive assays in HIV testing for countries with positivity of less than 5%. I think in the country it's less than that, and that's the recommendation, that we use the 3 test assay that we are shifting to. And the aim is that the first assay should be very highly sensitive, whereas the second assay now is more specific, or specificity is high in the second assay. And this for children below 18 months of age or younger, that's when or those who are under 24 months, if still breastfeeding, use of serology tests alone is insufficient in HIV infection. And this is because you may pick antibodies from the maternal antibody during that period, since it's not recommended. And in this scenario, virological test, that is typically the nucleic acid testing, or PCR, is recommended in this age group. So the issue, I think, to realize is when do you use long ELISA method, and this or laboratory testing, mainly for ELISA, and it's basically that you are in the hospital setting, and you want for blood screening, or blood screening within the in guidelines, it should be done through a long ELISA method, using laboratory method. For patients who are undergoing renal transplant, for screening, they also have to be screened through a long ELISA method. The question that arises is, sorry for my sorry for that. The question that arises, is there a ELISA method better than the rapid tests? As I said earlier, it's only that you have ELISA method may be more accurate, but the testing protocol is the most important thing to follow in terms of when you are looking at diagnosis itself. Is the testing method that or following the national protocol, or rather testing protocol that is there, or the algorithm? That's the what is more important. But for in the hospital setup, definitely in blood screening programs, you use the long ELISA method or the laboratory method. Then we come to laboratory reports, and that in terms of sharing, issuing laboratory reports within the patients who have been diagnosed, or you have reports for the patient who has HIV, who are positive, then it should be handled as a confidential and within for the patient, and not disclosed as in any other, whether it is in VCT or as is handled in the VCT setup. Thank you. So sorry, I think I was to share the algorithm used in the lab. It's still the same two methods, whether you have you do the initial test, and if it's positive, it's negative, then you report it as negative. Then if if it's positive, then you subject to another test. Then if it's positive, then it will be reported as positive. However, if it turns negative, then you have you follow the algorithm that Janjera has presented. You either refer the patient to come after 14 days, or you can refer to do PCR or provide DNA. So, thank you.
Thank you, Dr. Diangui, for that presentation. It was quite informative. So I think because of time, we'll just go straight to the Q&A. There are not many questions, so we should be done maybe the next 15 minutes. So the first question there, someone is asked, is there a way to reduce the turnaround time, given the emotional status that comes with testing? So maybe I'll direct it first to Angela, and then Dr. Ndiangui, you can also comment on the turnaround time for lab tests.
I would say, yes, it's possible to check on the turnaround time, and also in the program, the HIV program, when we are testing for our clients, most of the time we give the result there and then within the same testing point, so that the client gets to know what results they have. In the event where there is need for further testing, then the HIV results are already provided there and then. However, probably with the retesting for a positive result, and then for initiation to care, we here at Kenyatta, we actually work very fast, so that if a client has tested positive and they need to be tested by a second tester, they will be quickly, if they are walking clients, they are walked to CCC, where there is a HTS provider waiting for them. And at CCC, they are also checking on their TAT, and they ensure that that client is tested as quickly as possible. And then the other services continue for enrollment. If the client is in the ward, equally the same is done. The client, the first tester will quickly call another tester, and the patient will be tested, retested, and initiation into care process will start. Same case for PMCT. If the client is tested positive, retesting will be done right away there at CCC, or rather at PMCT in the clinic. And right away, again, they will be initiated into care in the same place. So we try our best to ensure we reduce on the turnaround time. Thank you.
Maybe over to you, Dr.
Thanks,
Ndiangui.
Angela. I think you have put it correctly. I think, yes, the turnaround time, I think, especially in the lab, probably when you have only the lab request form and the specimen without the client following up, and so the turnaround time within 2 hours in the long ELISA method is usually results are out within 2 hours. They are available to the clinicians for review and passing to the patient, to the client.
Okay, thank you. So the next is more of a comment. So Rennie is asking us to share the slides. So the presentation will be shared on the KNH YouTube channel. The next question, James is asking, has it ever happened that a client who is positive and in care turned negative? If so, in which scenarios? And if it happens, what is the way forward? So maybe I can just comment on that. Yeah, so this is a patient who is, I'm wondering whether it's a patient who is already on antiretroviral therapy, because it is known that when you're on antiretroviral therapy, if you're tested, you could turn negative. It's called seroreversion. So what happens is that when your viral load is suppressed, the immune system no longer has that stimulus to continue producing high levels of antibodies. So it's possible your antibody levels could decline and could not be detected by testing. So you're not supposed to test a client who is positive, found to be positive, and who is on antiretroviral therapy, because in that case now you'll get false negatives. Maybe to the patient it will look like a miracle, but really when they stop their treatment, then the HIV virus will rebound. I don't know if anyone has a comment. Okay, yeah. So I'll move to the next question. So this one maybe is directed to Angela, because Roslyn is asking, who is repeating the TRIN screen, the first or the second tester?
Thank you, Roslyn. With this, if it's in PMCTC setting, the second tester we'll retest with TRIN screen. However, in the 3-test algorithm, the 3 tests are done by one person. So even the repeat testing for TRIN screen in the event of a reactive 1 step or test 2 will still be done by the same person in the 3-test algorithm. But if it is at a retesting point, then a different person will do the retests, not the same person. I hope that is clear.
Thank you. So the next question, someone is asking, Osoro is asking, most of our level 2 health facilities have no established labs. And I can confirm that the tests are done there, but don't think they follow this procedure, what we have presented. So maybe since it's relating to lab, maybe Dr. Ndiangui, you can answer. How can you help Osoro?
Thank you. So I think I don't know how to comment on this because it's an allegation probably that it doesn't think that's what is followed. But as Angela has stated, and as I stated in my presentation, it's all about following the national guideline algorithm. Because you don't deviate from that at all when they're doing the test. Remember, all these are in public facilities, and we all use guidelines. So I think it's upon to sensitization on whoever is doing the test to follow the guidelines. As long as you follow the guidelines, that's all is required for you to get an accurate result. But I may not be able to comment on the particular issue or the thing.
Okay, thank you. I think that was a good response. So the national guidelines are available on the website, on NASCOP website online, so the participant can access them there. So the next question is from anonymous attendee. Someone is asking, kindly confirm, is determine test being done away within the 3 tests? That can direct to Angela.
Yes, from what the presentation we have done, yes, determine kit will be done away with and replaced with the Trin screen kit as the first test in the algorithm. Thank you.
Thank you. So next question, Elizabeth is asking us to highlight on the testing of a baby delivered by a HIV positive mother. Do you have the algorithm?
Hey, I don't have it here.
Okay.
But it is, of course.
Okay.
What would be expected on this if the baby is delivered by a mother who is HIV positive? Then what usually would happen is, because the baby, depending on the age of this baby, if they are under 18, we still cannot say we've diagnosed them with a rapid test, rather with antibody test, though they would still need to be subjected to the nucleic acid test, the PCR. What can be done? The rapid test can be used just for screening, just to be able to see whether the child is exposed or not. However, that is not diagnostic until a PCR test is done for the child, for the baby. If it is a baby who is under 18 years or 18 months, 18 months of age.
Yeah, thank you. So the next question is asking, how would someone on HERT test negative and will he or she still transmit? So I think we had explained earlier that if you're on treatment and your viral load is suppressed, then your immunity, the lack of exposure to the antigen may lead to the antibody levels declining sufficiently that they may not be detected by tests. Yeah. So if the patient stops treatment and the virus replicates again, they can be able to transmit the infection. So the next question, someone is asking, saying some clients dispute results even when they are sent to several labs. They can become violent and threaten to harm investigators. They even refuse counseling. So they're asking, what is the way forward for such clients who refuse to accept results? Maybe Angela.
Thank you for that question. I think we had talked of creating an enabling environment for clients as part of the 6 C's. And the 6th is about creating an enabling environment to be able to address such as clients as those who would turn violent. And I think what really one would do is just to ensure that it's just about counseling, working with them, talking to them until they are able to then accept their results, essentially, with that reassurance and supportive counseling. Thank you.
Okay. So I think there are 2 more questions, maybe the last questions. So I think I'll direct to Angela again because it's related to testing. So Otieno is asking, why put someone directly on treatment if tested syphilis positive, but when they're HIV positive, you have to do another confirmatory test? Yeah, why no confirmatory test for syphilis?
Thank you. Thank you for this question. I think our main concern for testing for the syphilis is to protect the unborn baby, more so for the mothers or the breastfed baby. And so we want to ensure that they do not, the baby is born free of syphilis, not infected. And that is why the mother then testing positive for syphilis, actually at that point would be put on treatment right away And this is treatment for these antibiotics. And after a short while, the expectation is that once they go through that and they go through the course and well, then they'll have responded well, and probably they will not be able to transmit syphilis to their unborn baby. So this time, the focus is more on the child, more on the unborn baby. And that is why we do not even necessarily have to do retesting.
Okay.
Yeah.
So the last question, someone is asking, what should one do if a HIV reactive mother refuses her child to be initiated on prophylactic treatment? I think this one goes to Angela because it maybe speaks to counseling.
We thank you for that question. It is very tricky, but again, we also remember the rights of every person. There is the right of the mother, and there's also the right of the child. And I think what the mother needs to be helped to accept is that the child has their own life to lead and the mother has their own life to lead. So it's a question of just providing that counseling, education to them, support them until they see and appreciate the need for treatment for this child, who is another life, a unique person, as opposed to them, the mother, who is also another life. So we are protecting life. However, the life is under the care of the mother. So the mother needs to be given a lot of support, counseling, and education. But again, the child has a right to treatment and living.
Yeah. So there's a question there, a last question that has been sneaked in by Otieno Adero. He's asking, can HIV testing proceed if the client declines pre-test counseling? Yeah. So remember, we had talked about the rights of the patient. So if the client declines, then the client has the right to refuse to be tested. Yeah. I think that at that point, we've reached the end of our presentation. So maybe what we'll do is I'll give Dr. Ndiangui and Angela a chance to give their last remarks. Maybe starting with, starting with Angela. She wants to comment on the last question.
Thank you so much, Dr. Juma. Just want to ride on your response and just say that, like I had said earlier, in the program, more so when you are giving the results right away, it's a package. We give it as a package. And so we would encourage that everybody takes up the pre-test counseling. But if they decline to take the pre-test counseling, then it can be difficult also just to test them, because when you just test, you don't know how to go ahead depending on the results that you'll have received. So we encourage the aspect of pre-test counseling, then testing. Thank you.
Okay, thank you, Angela. So over to you, Dr. Ndiangui, if you have any last closing comment.
Yeah, my closing comment, maybe you allow me, there's another comment I saw on the chat about someone was asking to comment on the blood screening, blood transfusion screening. Just to comment is that for blood transfusion, as I alluded, it is done by long ELISA method, that's the laboratory method. And of course, you don't have an algorithm as long as, because you are using a very highly sensitive test. If it is a positive, then of course the unit is discarded, and you have what we call the triple serology, that is hepatitis B, C, and HIV. I think my home message is that is about the testing algorithm. That's what should be followed, and to appreciate that in laboratory testing, in any test, usually is a trade-in between being very sensitive. So if you are being you want the test to be very sensitive, then you risk of having a false positive. And trading between specificity, then you may have a false negative. So that's the trading. There's no test which is 100%. And therefore, as we handle our clients and testing, that's the point that you are taking home. And that's why the government takes very steps to have the testing algorithm to be followed by each facility, so that it's standardized across, whether you are being tested in KNH or you are being tested in a low-level facility. That's my take-home message.
Thank you. That was very clear. So I think that brings us to the end. Thank you for joining us. And just to encourage clinicians to adhere to the clinical algorithms for testing for HIV. They have been proven through research to be the best way to minimize or misdiagnosis of HIV. So thank you very much for joining us. Good evening.